can everyone answer this question? And I'll ask someone else. So what is shunt? Actually, I might just ask someone, who wants to volunteer? What is shunt?
So shunt can be physiological or pathological, but it is blood that enters the left atrium without participating in the gas exchanging units of the lung.
Yep, that sounds good. And yep. Blood that enters the arterial system and bypassing the ventilated areas of the lung. What is some examples of shunt?
So you might have blood that enters a non-ventilated alveolus. You might have right to left shunting through, so like having a PFO or an atrial septal defect. And then a physiological example would be the thespian, I can't pronounce that word, but you know, the thespian veins.
Thespian.
Thespian, thank you. Sounded like I was trying to talk about an actor, a thespian vein. Or the bronchial circulation would be another one.
Yep, sounds good. How about what are some other pathological states?
Other pathological states. So it's
lung states.
So essentially it's VQ mismatch. So anything that, so you could have sputum plugging, you could have airway collapse as a result of, say, increased closing capacity. You could have really high pressures in your alveolar units because of barotrauma, or like over distension. So you're ventilating someone with a volume that's too high.
Would that cause shunt or dead space?
So that would be ventilated, but that would be ventilated but not perfused. Sorry. Yeah.
No, that's all good. Yeah. So I think there's all your usual stuff, but then anything really like pneumonia, sputum plugging, atelectasis, lung collapse, asthma, these can all cause shunt. Okay, so let's get into this, which is define venous admixture. Actually, just before we get into that, what is PE? What does a pulmonary embolism cause?
Asking me again?
Oh no, okay, yeah. Anyone's good. I'll pick on you, not Meg. It's all good. Anyone want to? Actually, I'll pick on someone else. What do you reckon, Luke?
Pulmonary embolism causes an increase in dead space because occluding the pulmonary blood flow means that those alveolar units are ventilated but not perfused, and that means that the blood that otherwise would have gone to them has to divert to other alveolar units.
So when we learnt pulmonary embolism back in med school, so I agree with you. If you get a blockage because of a big pulmonary embolism, that will cause a dead space. There won't be any flow to that segment of ventilated pulmonary capillary and alveolus. But why is it that then we think of, back in med school, back in whatever, pulmonary embolism is a cause of hypoxemia? Is that true, or has it been false all this time, or?
I mean, it's true because we observe it. So the pathophysiology of hypoxia in pulmonary embolism is complex. I think, I don't understand it fully, but I think that it's got to do with conversion from perfusion to diffusion limitation. It could be to do with the tachypnea. I think they get is due to stretch receptor activation and other mechanisms, I think. But I don't quite understand the pathophysiology of the hypoxia, but I know it's complex. So
no, that's right. So the first thing is it is complex, and when I read this back in the day, it was again, it just seemed odd that PE is dead space, but it does cause hypoxemia. So when I looked it up, it was exactly that answer, and I think either Nunns or some other pathophysiology textbook. But essentially, it is a complex thing that happens. But a pulmonary embolism isn't just a clot blocking part of the lung, the lung vasculature. It causes inflammation, and that inflammation can cause shunt, because then it will cause problems with the alveolus itself. But also a big enough pulmonary embolism will now cause VQ mismatch, because there's blood flow going to other areas of the lung and making them suboptimally ventilated and perfused. So there's all these other reasons. And so you're right to say it's complicated. And that's why technically it's dead space, but it has all these other effects. So let's do this one again.
Just with that last, sorry, if I could just ask one more question.
Yeah.
Sorry, in terms of the inflammation that you get, I mean, I would imagine that the inflammation you get primarily in the area that's you've occluded, which is not going to get any blood flow. It might be in some neighbouring areas that are perfused, and that could explain, I guess, a bit of hypoxia. I guess, is it explainable by conversion of perfusion to diffusion limitation, where essentially the blood flow that was going through those alveoli are now much faster because more blood needs to go through each of the other alveoli lung units, and therefore, switching a perfusion to a diffusion.
Look, it may, but again, I don't think anyone knows, because it would be such a hard thing to measure. Hey, that's a decent theory. If you can talk through it, fantastic. But yeah, even when I read this little section, they weren't sure either. So it sounds like one of those things that no one really knows.
Good.
For sure. Let's go through this. Another big part of the syllabus is define venous admixture and briefly explain how it influences arterial oxygen tension. So yeah, again, definition, causes, draw some diagrams, and how you measure each of these. How do you measure each? So this is the shunt, the shunt equation. I might just put this up actually. So take 5 minutes, practice drawing these things. If you know that picture, don't look at it, just draw it. Yeah, I'll ask someone in 5 minutes or so.
So in terms of what is the definition of venous admixture is the amount of deoxygenated blood that would need to be added to pulmonary capillary blood to explain the difference in PO2 between pulmonary capillary blood and arterial blood.
And that deoxygenated blood, is there a particular term for that?
Deoxygenated would be the blood that's returning to the lungs that would be found in the pulmonary artery. So
yeah, mixed blood.
Mixed venous blood, correct.
Fantastic. Good, keep going.
Thank you. Yeah, sorry about that. Yeah, good.
Sorry, what was I going to say? So there's something peculiar about this. Like, is this something you can actually sample and measure?
It is possible to measure, although it's a bit difficult. You need to have a lot of lines. So you can calculate it, but I think it would be fair to say you can't measure it because it's...
Yeah, that's right. You can calculate, but you can't measure it. And so it's a completely theoretical thing. So if it was just shunt, actually, to tell me, yeah, keep going and we'll get to it.
So it is the theoretical amount of deoxygenated blood that must be added to the pulmonary capillary blood, but it sort of represents a net sum of the various forms of shunt that occur in the lung.
Yeah, that's right. A theoretical amount of mixed venous blood that must be added to explain that difference. Keep going.
So the shunt equation of Berger is shown on the screen, and the way in which it's derived is that it utilizes the mass law of conservation of mass, and that means that the amount of oxygen returning to the lungs, which is QT times CvO2, which is the oxygen content of mixed venous blood, must be equal to the amount of oxygen that is flowing through the shunted portion of the lung, which should be equal to QS times the mixed venous oxygen content, times by, that's one factor, plus the non-shunt blood flow, which is QT minus QS, multiplied by the oxygen content of the pulmonary capillary blood, CCO2, that's there in that diagram. From there, that equation can be rearranged to demonstrate the shunt equation of Berger, which shows that the shunt fraction QS on QT is equal to pulmonary capillary minus arterial oxygen content divided by pulmonary capillary minus mixed venous oxygen content.
And that's great. So you went through a whole bunch of the principles to get there, which is actually pretty good to know. But at the end of the day, you could probably just reproduce this equation. And normally I'd say it's nice to be able to work something out, but the fact is that it would take quite a bit of time to draw it and work it out. In the now 5-minute segment vivas, I just cannot imagine that happening. So, just practically speaking, QS on QT equals, CCO2, take away CaO2, etc. Now, so how would you actually, again, the examiners that I've known have been really into how to get these values. So how do you get each of these numbers here?
Yes, so each of these values is an oxygen content, which can be calculated using the oxygen content equation, which is hemoglobin concentration in grams per litre times oxygen saturation times the oxygen solubility constant 1.34 Huffner's constant plus 0.03 times PaO2 will give you the mils of blood in 100 mils of mils of oxygen, 100 mils of blood. So then in order to solve for each of these, you would need to know the oxygen saturation at each of these particular points,
Yes.
the hemoglobin for these, and the so the hemoglobin can be measured using just one blood test.
Yes.
And the arterial oxygen saturation could be measured either as an estimate using pulse oximetry, but more accurately using an arterial blood gas.
Yep.
The mixed venous oxygen saturation and partial pressure can be measured using a pulmonary artery catheter that's situated in the pulmonary artery, like a Swan-Ganz catheter.
Yep.
And then the alveolar oxygen partial pressure can be calculated using the alveolar gas equation, and then substituted into the oxygen hemoglobin dissociation curve to give an approximate saturation and therefore content that would be running through pulmonary capillary blood.
That's a great explanation. So for everyone, just to reiterate, I can get all these values with the oxygen content equation, which is a combination of this hemoglobin bound oxygen plus soluble oxygen, and that's a factor of SATs 1.34 for the HB combination equation, and how much is dissolved, which is Henry's law for diffusion, which is 0.03, depending on the amount, depending on your units. And yeah, you can get your saturations based on an oxygen hemoglobin dissociation curve with the alveolar gas equation, and then the rest of the values you can get with an ABG and a pulmonary catheter. So great, that's how those values are derived. Tell me about the causes.
So there are a number of causes of shunting and venous. Is it venous admixture or shunting you're speaking about in particular?
As in the causes of venous admixture would include those of X and Y.
Sure. So mainly it's in the setting of true shunt, where the VQ ratio is 0 and can occur either, as Meg was saying, in physiologically or pathologically. Physiologically would be, again, due to the bronchial circulation or due to coronary blood flow, including the Thebesian veins. And then pathological could include intracardiac shunt, left to right shunt, intrapulmonary shunt with an arteriovenous malformation, for instance. And those are the causes of shunt. There's also this sort of physiological functional area of shunt, which is also known as VQ mismatch, where the VQ is not 0, but it's between 0 and 1, and can include alveoli that are better perfused than they are ventilated, and might occur in such states as consolidative processes like pneumonia, alveolar edema, like in pulmonary edema and congestive heart failure. That's
an interesting principle. Even in the absence of any pathology, if you look at the lung from base to apex, none of these segments are perfectly 1-to-1. They're less than 1. They've got sometimes, if they've got better perfusion, they've got ventilation, you're always going to have lower, less oxygenated or suboptimally oxygenated segments. And these contribute little amounts of less well oxygenated blood. And all of this combines to be VQ mismatch or VQ inequality. And you put them all together in this very theoretical method, and you can provide this amount of venous admixture. Does everyone understand that? I also realize that, like, everyone's going to be at different levels in their study. So, feel free to ask even whatever you think might be a dumb question, because it'll definitely be relevant to someone.
Can I just ask, what would you give as pathological examples for low VQ as opposed to pathological examples for shunt? I think, like Luke said, things like consolidation. I classically think of consolidation being as where you blocked off something completely, there's no ventilation, that's true shunt, as opposed to you've got some ventilation occurring, but it's not appropriately matched to the amount of perfusion.
I think he was right to say any of these lung abnormalities. For example, asthma may have some segments that are completely blocked off, but may have some segments that are suboptimally blocked off. So I can imagine that a lot of the pathologies through the spectrum of their severity will cause anywhere from VQ inequality to complete shunt. So yeah, I think you could just talk about it and put it anywhere, really. because we won't know unless we look at the individual lung unit. Okay, good. So this is roughly your the drawing that you'll find in West's. I'll just see what I've written about it. Ms. Mason, what does this graph demonstrate?
So it is on our x-axis, we have the partial pressure of oxygen in different regions. On the y-axis, we have the oxygen concentration of mils of oxygen per 100 milliliters of blood. At various points on so starting the first point marked on the left-hand side, upper end, is reflecting our pulmonary and capillary blood. Yep, where you've got your cursor now. And so the oxygen, partial pressure and content at that point reflects a mixture of supply, mostly from the upper of the two pathways on your diagram, which is from alveoli, which are both ventilated and perfused, but also includes some components of venous admixture, which in this diagram is being demonstrated by a true shunt, a small pathway which has perfusion but no ventilation occurring whatsoever.
What do you make of the drastic drop in your PO2? What do you make of that?
So I'll just take a moment to think on that.
And this is
oh, sorry, you go.
Ask that, it's drastic. Actually, no, you go. What do you make of it?
I'll say I would presume that that significant drop is largely as a result of the shape of the oxygen hemoglobin dissociation curve, in that between a very small change in saturation is actually reflecting of a significant change in the overall content, and therefore while you're diluting with a small volume, the amount of oxygen content within mixed venous blood is significantly lower than that in arterial blood. And
I mean, when you look at the drop from pulmonary and capillary oxygen concentration to, when you include the shunt, so in capillary versus arterial, there isn't like a huge concentration drop, right? And so really, it seems to me like the body defends the absolute amount of oxygen content very well because of the shape of the curve. So this facet of evolution and the oxygen hemoglobin dissociation curve means that even with a bit of shunt, like it's happening here, your oxygen concentration doesn't go too far below 20, even with a little bit of shunt.
And I suppose in this diagram, is it kind of suggesting, we've got a patient breathing 100% oxygen as opposed to room air? So.
Yeah, that's right. Yeah. Does the shunt affect PCO2?
So the answer is both yes and no. I'll start with the yes component. Yes, any shunted blood which does not participate in gas exchange results in impaired transfer of CO2 from the blood to the alveoli to then be ventilated away. So this will result in a small increase in arterial CO2. However, the CO2 ventilation response within your various chemoreceptors is so closely matched that patients who are spontaneously ventilating will tend to increase their ventilation rapidly, such that arterial CO2 changes minimally.
Fantastic. So imagine that all of this CO2 that's in the shunt area won't be getting breathed off. Therefore, the CO2 will rise a little bit, but then your chemoreceptors jump into action and hyperventilate so that your CO2 returns normal, because the chemoreceptors just really, really defend a PaCO2 of a certain level, say 40. Construct me a situation then when the CO2 would increase.
So if you have a patient who is anaesthetized, plus or minus paralyzed and being mechanically ventilated, such that they are not driving their own minute ventilation, but they are subject to what we are controlling for them, if that patient then develops shunt for whatever reason during the course of their anesthetic, and they are not able to increase their ventilation proportionally, then we would expect to see an increase in arterial CO2.
How about non-anesthetized patients? How would that work? How could you increase CO2 in them?
This could potentially be observed in patients who are already ventilating at close to their maximum ventilatory capacity, either to do with significant lung disease such that they have less reserve to increase it above their baseline.
Yep. That's true. So imagine someone has no more ventricular capacity, then you can't increase your ventilation to defend this PCO2. So that's absolutely right. Any other situations? Non-anesthetized patients, they're still at a normal level of ventilation, say, or within normal ranges. Look, I was just thinking if they're affected by opioids or other drugs that affect the ventilatory drive.
Yeah.
Good. And I feel like a lot of this exam will be just exploring a little bits of these hypotheticals. Once you get the basic answer, just take it the next step and go, what if? And I feel like a lot of you guys are already doing that, which is really good. And we've explained why. So next person, this will be like the final question. Who wants to explain what this is? Yeah, anyone jump in?
I can give it a go, La.
Go for it.
So this is the iso-shunt diagram, which basically sort of shows you the effect of a shunt, depending on how much shunt you have, 0, 50, 10, or whatever, and what it does for a given inspired FiO2, and what it does, and what you expect you might see with your arterial PO2. So that's why on the x-axis we have our FiO2, and then on our y-axis we have our arterial PO2.
Yeah, good. And you like the good thing you're just saying true statements. I've got inspired oxygen concentration and the PO2 increasing with changes in inspired oxygen concentration, and how it works for different fractions of shunt at certain constants. You know, HB of this amount, PaCO2 of this amount, and the AVO2 concentration difference of this amount. And you may have mentioned this, sorry. And what do you make of this? Like, why is 5%, 10% looking like this, and why is 25, 30, 50 look like that?
Yeah, so there comes a point where increasing your FiO2 will not increase your arterial PO2 anymore, depending on how great the shunt is. So for example, with 0 shunt, as we're increasing our FiO2, we can get that increase in PaO2. But if you get 50% of your blood volume being shunted across, no matter how high, once you reach FiO2 of 100%, you can never increase your PaO2 anymore.
Yeah, that's right. Now, it's interesting, when I read a bit more about this iso-shunt diagram, in ICU, you could measure so you can imagine that if you increase oxygen concentration and then graph that for any individual patient, you will get a series of, points. Depending what those points look like and what the line looks like, you can actually estimate the degree of shunt. So apparently they used to do this in ICU. They would increase FI, take some blood gas measurements, you got the arterial PO2 and the FI values, and you could calculate the rough shunt diagram or where this patient was sitting. And so I thought that was quite interesting. And again, maybe another practical application in the Viva if they start asking you about this. Just to reiterate, you did good things there, which is just state true things about, like, say you've never seen this before because you haven't read this part of Nunns, you could just read exactly what's on there, say some true statements, x-axis values, y-axis values, what each of these lines represent, and then just look at them and read them and go, there's a difference between 0 shunt and 50% shunt and very minimal increase in oxygen with increasing FiO2. The larger the shunt becomes, so it's pretty much, it doesn't even really make a difference at above 30%. Excellent.
Can I ask, are there any particular points on that graph that you choose to memorize or you think are of particular utility? It seems to be like the 50% shunt. At that point, basically, your arterial will just almost equal your mixed venous. Are there any other points that you?
I remember when I learned this, I literally just drew lines, and by the time it got to 25, 30, 35, that was really where I started. Like the important point that even Nunns talks about is 30%. So I'd include my 0, 5, and 10 are straight lines, 30 and 50, because those are the important points. That's personally what I did. I didn't get too detailed in it because, again, the diameter of each of these lines also is important, that there's a range as well when they've done the experiment on this. So I didn't bother with the width of these lines either, and I kept it very brief.
Thanks.
Yeah. Hey guys, that's all for today. So it's 11 o'clock. That's good. What we went through, discussing the lung volumes and capacities, their measurement and normal values, discussing dead space, its measurement, applying the Bohr equation and the alveolar gas equations, describing the composition of ideal alveolar and mixed expired gases. We did the oxygen cascade. alveolar exchange of oxygen and carbon dioxide, diffusion capacity and its measurement, and discuss normal ventilation perfusion matching. Great. So next week, sorry, not next week, a couple of weeks' time, we'll go through these topics. So measuring ventilation perfusion inequalities, carriage of oxygen carriage in blood, the hemoglobin oxygen dissociation curve, carriage of, difference between pulmonary and systemic circulations as well. Yeah. And then pulmonary vascular resistance and some non-ventricular functions of the lung. And we'll get through that pretty quickly. So we'll go through some of the more, practical stuff, questions that we've done that have existed in the previous SAQs. But yeah, thanks very much, guys. And I'll see you in a couple of weeks.
Thank you.
Thanks, Ian.
Thanks, Lahir.
Cool. See you guys. Bye.
Very much.